In this video, we will discuss the DANAMI-2 trial. In STEMI patients admitted to the hospitals with angioplasty facilities, the primary PCI is considered superior to the fibrinolysis. However, in STEMI patients who require transportation from a community hospital without angioplasty facilities to a center with such facilities, whether the superiority of primary PCI over fibrinolysis is maintained is unknown. Thus, the objective of this trial is to compare the transfer of patients for primary PCI with on-site thrombolysis in acute myocardial infarction patients with ST segment elevation. Patients at least 18 years of age with presence of symptoms for at least 30 minutes but less than 12 hours with cumulative ST segment elevation of at least 4 mm in at least 2 contiguous leads were included in this study. Acute myocardial infarction and fibrinolytic therapy within the previous 30 days, LBBP, contraindications to fibrinolysis, previous CABG, non-ischemic heart disease, diabetic patients treated with metformin, pulseless femoral arteries, renal failure, and non-cardiac disease associated with a life expectancy of less than 12 months were the some of the exclusion criteria. Now let's go through the endpoints of this study. A composite of death from any cause, clinical reinfarction, or disabling stroke at 30 days was the primary endpoint, while a composite of death from any cause, clinical reinfarction, or disabling stroke at the end of study, total and cardiac mortality, and angina-free survival without acute myocardial infarction at the end of the study were the some of the secondary endpoints. So a total of 1,572 patients were included in this randomized clinical trial, with mean age of patient being 63 years and mean period of follow-up being 30 days. 27% of the study population was females. 24 referral hospitals without angioplasty facilities and 5 invasive treatment hospitals with such facilities and on-site surgical backup were included in this trial. Transfer to the nearest angioplasty center had to be completed within the 3 hours. Thus, the study population was randomized in 1:1 fashion to receive either primary PCI or fibrinolysis with alteplase. All patients received aspirin 300 mg followed by 75 to 150 mg daily, IV beta blockers, and unfractionated heparin. In case of stent placement, ticlopridine 500 mg or clopidogrel 75 mg was given daily for a period of 1 month. Thus, in this trial, the median time from the onset of symptoms to the randomization in case of total population was 135 minutes. The median transfer time, that is the time from the randomization at the referral hospital to arrival in the cath lab, was 67 minutes, while the door to balloon time was 112 minutes in the referral center patients and 91 minutes in the on-site facility center patients. Two simultaneously conducted sub-studies were included in this trial for statistical analysis. The first sub-study included patients who underwent randomization at the referral hospitals, while the second sub-study included patients who underwent randomization at the centers with invasive facilities. And the analysis was done for each sub-study separately and for both the sub-studies combined together. So now let's go through the results of this trial. First, let's go through the clinical outcomes at 30 days. At referral center hospitals, the primary composite outcome occurred in 14.2% patients in fibrinolysis group compared to 8.5% patients in angioplasty group, while at invasive treatment centers, the primary composite endpoint occurred in 12.3% patients in fibrinolysis group compared to 6.7% patients in angioplasty group. Similarly, the rate of reinfarction was significantly lower in angioplasty group at both referral hospitals and invasive treatment centers. Thus, at both referred hospitals and invasive treatment centers, the primary composite endpoint was significantly lower in the angioplasty group, mainly because of significant reduction in the reinfarction rates. At referred hospitals, the rate of disabling stroke was 2% in fibrinolysis group compared to 1.6% in angioplasty group. So no significant difference was observed between two groups at referred hospital in terms of disabling stroke, while at the invasive treatment centers, the rate of disabling stroke was 2.3% in fibrinolysis group compared to 0% in angioplasty group. Thus, at invasive treatment centers, the rate of disabling stroke was significantly lower in angioplasty group. Further, no difference in the incidence of death was observed between two groups at both referred hospitals and invasive treatment centers. Now moving to the clinical outcomes at 30 days at all hospitals. The primary composite endpoint occurred in 13.7% patients in fibrinolysis group compared to 8% patients in angioplasty group. Similarly, the rate of reinfarction was 6.3% in fibrinolysis group compared to 1.6% in angioplasty group. Thus, overall, when results from both sub-studies combined together, the rate of primary composite endpoint was significantly lower in the angioplasty group, mainly because of the reduced rates of the reinfarction. While the rates of death from any cause and disabling stroke did not differ significantly between two groups at 30 days. So the 40% and 45% reduction in the rate of the primary composite endpoint was observed with primary PCI in patients enrolled at referral hospitals and those patients enrolled at centers with invasive facilities respectively. And this benefit achieved with primary PCI was predominantly because of relative reduction of 75% in the rate of clinical reinfarction in overall patient population, whereas no statistically significant reduction in the risk of death and stroke was noted. The pre-specified subgroup analysis demonstrated consistently lower rate of primary endpoint in angioplasty group. Among the 62 patients who had clinical reinfarction during the follow-up period, the 30 days mortality was 24.2% compared to 6.5% among the remaining 1,510 patients who did not have clinical reinfarction. Thus, the 30 days mortality rate was significantly higher in patients who had clinical reinfarction. Further, the inclusion of the procedure-related reinfarction in the analysis of clinical reinfarction did not change the results of this trial. So now moving to the interpretation of this trial. In patients presenting with ST segment elevation myocardial infarction, primary PCI is superior to fibrinolysis even when patients are admitted to hospitals without angioplasty facilities and then transferred to invasive treatment hospitals. And these benefits of primary PCI were same for both patients transferred from community hospitals and for patients admitted directly to a center with invasive facilities. So the transfer of patients to a center with invasive facilities for primary PCI is superior to on-site fibrinolysis provided that the transfer takes 2 hours or less. Now moving to the outcomes of this trial at 16 years follow-up. The main endpoint at the 16 years was a composite of death or rehospitalization for myocardial infarction. In overall cohort population, the composite endpoint occurred in 58.7% patients in PCI group compared to 62.3% patients in fibrinolysis group. Similarly, in the case of patients transferred for primary PCI, the composite endpoint occurred in 58.7% patients in PCI group compared to 64.1% patients in fibrinolysis group. In addition, the reinfarction occurred in 19% patients in PCI group compared to 24.5% patients in fibrinolysis group. Thus, the composite endpoint and reinfarction were significantly lower in PCI group compared to fibrinolysis group at 16 years follow-up. Similarly, in terms of cardiac mortality, an absolute reduction of 4.4% was observed with PCI, while no difference in all-cause mortality was observed between two groups. Thus, the primary PCI delayed an average time to a main event by approximately 1 year. Thus, overall, the superiority of PCI over fibrinolysis was maintained even at 16 years after the procedure. So, these are the references you can go through for further details.